didn't think I'd be making an internship survival guide, but I guess this is the absolute basics of how to survive your first year as a doctor. Brought to you by me. Whatever that means. Anyways, let me take you through it. This is going to be my guide to surviving your first year as a doctor. The absolute bare basics, just keeping your head above water, much like this image, which shows a duck and points to the duck as being you, because you're the intern, because you're just keeping your head above water, but below the surface of the water, it's absolute chaos. It's a frenzy with your little legs just trying to keep afloat and paddling furiously. So yeah, this is everything that I've learned and probably wish I knew before I started my first year as a doctor, and how I could have just made my life 10 times easier. So just a few basic things you should probably get your head around before you rock up to work on day one, probably in a few weeks time. So it's gonna happen very, very soon. There's gonna be a whole bunch of new interns coming into the hospital system. Good luck. And yeah, it should be fun. So let's go through it. All right, so let's get right into it. As I said, you're this duck and you're going to be surviving, just keeping your head above water, and your legs are going to be paddling absolutely furiously. So let's go through the first thing. So I think one of the first things to go through is your clinical skills and just your practical knowledge of the hospital as a junior doctor. I mean, it's going to be very, very tricky for you to just soak up everything about how the hospital system works, the layout of it, where things are located, how to get to the hospital on time, where to park, do you need to set up parking? You know, at the hospital we do have a lot of staff car parks, and you might have already been exposed to that as a medical student, or maybe you're just like, you know, cheapskate like me and just park on the street, and you know, you just don't want to have to deal with that, but you need to know where the free parking is, and you need to know how long it is going to take you to go to work. And what if there's traffic, and what if there's not traffic? Because you don't want to be, you know, late as an intern on your first day and have like this constant like stress about where to park and how to sort all that stuff out. So that's just like a headache that you can just avoid by doing a little bit of research and, you know, having a chat to a few of the other doctors who are already working there, etc. I mean, having your logins all sorted, you probably got an email from someone who's just you know, introduced you to you know, the health network, and they've given you a whole bunch of logins that you have no idea what they do, and you know, just having them stored on your phone in like a notes app or something is going to be super helpful. So when you do have to log into the computer to type the first ward round note, you're not frantic and you're just like guessing random letters in the keyboard. So having those stored in a nice secure place, practicing like actually logging them in to see if they work and see if they actually, you know, actually get you into the hospital system. Otherwise you may need to call IT and sort that out, because that's just something that's such a pain in the bum. Like when you first start out and your logins don't work and you need to spend like half an hour on the phone to IT. If you just like spend like a few hours, if you like spend like an hour or two in your introduction week before you actually start your first shift as a doctor, on the phone to IT if you need to, just making sure your logins all work, that would be super helpful come day one. And I guess just making sure your swipe cards are all sorted as well, and making sure you actually bring your swipe card every single day. I think a day without a swipe card in the hospital is an absolute nightmare. You just can't get to wherever you need to get to, and you're constantly just like waiting for people to like let you into places. So swipe cards are an absolute must, and make sure they actually work and swipe you into places. Otherwise just fix it with the hospital security system, or, you know, talk to the security office and get them to give you access to wherever you need. Having an idea of the start and finish time to your shifts and when you need to actually rock up, and I mean, quote unquote start time is, you know, a little bit of a grey area, because say people want a ward round start at 7:30, then you might need to actually get there 10-15 minutes beforehand. You need to prep the list, you need to print it out, you may need to just like prepare the ward round notes or whatnot. It obviously depends on each rotation, but say a surgical ward round, if you're starting at 7:30, everyone's got places to be at 8. Everything needs to be sorted. You need to have a look up at the numbers about the obs overnight, get handover from the night team if there was any issues, and make sure you convey that to the morning staff. So there's a whole bunch of things about start time and flow of the actual unit that you're on, but it'll depend. Say if you're in ED, you probably just start at whatever time you start at. But if you're on the surgical ward and your ward round starts at 7:30, I'd probably get there a little bit earlier just to make sure everything is sorted, prepped, and ready to go. Because the rate limiting step for the ward round is the registrar, and you just need to make sure you facilitate that so that the round moves smoothly and quickly and everything's sorted. So yeah, that's just one thing. And then finishing time, just making sure you hand over and everything like that at the appropriate times and locations. Just say like you have an idea that I finish at 5:30 and like the hospital keeps running like after, I don't know, like it's just take yourself out of your own shoes and realize that after hours patients are still being looked after. Who are they being looked after by? They're being looked after by the cover person who stays around till about 8:30, and then after 8:30 it's a night person. So if there's issues or if there's things to chase or whatnot, then you need to actually convey that to the cover person or potentially the night person, and they need to actually have an idea about what they need to do for those patients, because yeah, you need to make sure they're safe and healthy and looked after outside of the main hours of working for the hospital. Having an idea about the types of shifts that you could do, whether it be a full normal day, a cover shift, a weekend shift, or potentially a night shift, unlikely as an intern, but you may have a short rotation of night shifts. I guess a full day is just like a normal day, like you start in the morning, you finish in the evening, and then you hand over to the cover person and then you go home. Then that could be around 7:30 till 5:30, give or take half an hour here or there. Cover shifts are when you stay back from 5:30 till about 8:30, and it's sort of bridging the gap between the day people and the night people. And yeah, that's just the cover shift. So if you're on that, you don't just rock up to work for 3 hours and then go home. You would do a full day shift and then hang around for an extra 3 hours until about 8:30, 8 o'clock. And that's when you hand over to the night people, and then you go home after that. I didn't put this in here, but you do have half days, depending on what, rotation you're on as a doctor. But if you're just on a normal ward job, you will have half days rostered into your timetable. And that's essentially when you go away at halftime. That's essentially when you go home at halfway through the day. So whether it's about 12:30, 1 o'clock, you get to leave early and go home, which is really good. And often there's another person there to cover you and sort out everything. So yeah, hopefully the half days are on quieter sort of days and there's not too much keeping you at work. But occasionally you won't have a half day, or you might have to stay back a little bit to do some overtime. Things do crop up at the hospital, so just bear that in mind. But I would try to take my half day as often as I could. You may also have to do a weekend shift. Weekend shifts, there's no good way around it. They're a little bit frustrating and they're busy because there's less people at the hospital, there's more patients to look after, and there's just less stuff available. So it can be very stressful. And I guess one of the main things you want to try to sort out is, before you get into the weekend, have an idea of what jobs may need to be done. And you get better at this over time, but having a weekend plan for the weekend people, so it's not a complete utter chaos when it comes to Saturday morning and no one has any idea who the patients are and what they do. And yeah, there is handover that goes on, but just making sure it's a smooth transition to the weekend. So when you're working a weekend, you'll have an idea about what you want and how everything could operate a bit more smoothly. But the other thing is a night shift, which it's pretty self-explanatory, but you will receive handover from the people in the cover shift or the day shift who are just hanging around way too late, and then you work all night, and then you hand over in the morning to the day people, and that handover depends on what unit you're on, but around about 7:30, potentially 8 o'clock or so if you're on the more medical units. And yeah, that's what you do, whether it's a cover on the ward, or maybe you're just doing like an ED shift or something. You're probably just doing those two as an intern, I reckon. There's not really going to be any interns who are going to be admitting all these people overnight. That's more of a resident registrar overnight job. So yeah, that's how the type of shifts work. And I guess I've just got a little diagram here about who's who in the zoo. You got your intern, then you got your resident who's PGY2, PGY3, and then your senior residents or unaccredited registrars, then your specialist registrars, and then you can have your consultants or fellows after that. And before that was you, medical student. So this is the basic overview of how everything works. And I think those are the few things to keep in mind, just the lay of the land, getting your head around things. That's going to be super, super helpful for you just getting started to the hospital network as an intern. And obviously there's so much more we haven't even covered, but having your thoughts around this area and just making sure you think about things in this way is just going to be the first step that you need to take. All right, let's go on to number 2. All right, so moving on to number 2, it's going to be just the basics of the ward. And I think the first few things that you start to do as a junior doctor is you essentially start to write notes, and it's a whole bunch of documentation, which is kind of boring when you get used to it, but it's really important, and you realize the importance of doing it over and over again, because documentation is absolutely critical to making the hospital system flow and making sure the plans are right, everything's medico-legally intact, and everything just flows more smoothly. Making sure you get good at this. I've got a few other videos just going through that, and I can link those in the description. But yeah, it's just going through the basics of how to get good at admission notes, ward round notes, and discharge summaries. Those are the basic notes. Of course, there's other things that you can learn about: how to do a verification of death, how to do a family meeting discussion, how to document open disclosure, and all these things. And if you're going to a hospital with an electronic medical record, they may have templates on their system, on their EMR or whatever, that you can use or adapt to whatever you want. Or there's different structures of things that people use to document everything. But having the bare basics understanding of it is really, really important. So I'd advocate for you to watch those videos that I made going through those, or you can have a look at some other resources and everything. But that's really important, documentation. The next thing is going through the list and handing over effectively. And the patient list, depending on what system you use, will either be a manual or automatic process. And essentially, if you're, say, on the cardiology unit, you'll have people who are under your bed card, who essentially you look after, you round on every day, and primarily you are responsible for their care, or the consultant under which the patient is under, their bed card, that's who is responsible for the patient's care. And if they are admitted under the cardiology unit, they will be your patient. You'll also have people who are on your consult list, and those are people who maybe the registrar might get chatted to about, or they might just be on a separate sort of adjacent list of consults to see. And there are people who are under different medical units, or not medical units like surgical units, or whatever they're under, and you're asked from your cardiology perspective what your advice would be. And that's really important, because we're not just single unit hospitals, and we don't just have one issue all the time. There are patients who have different medical conditions, and there's overlapping situations. But they might come in with a primary surgical issue, however they might have some cardiology things that crop up, and we need some advice about that, because surgical doctors are not experts in cardiology. Having the consults list managed correctly, and also your primary patient list managed, is important. And whether you just make sure the correct people are always added, or if there's new admissions overnight, having them on the list, or where they are in the hospital, what their bed number is, what their UR number is. Just having a good idea about all those things and making sure that if you don't need to see the patient, then they come off the list. Or if someone's forgotten about, then they just make sure you get them added back onto the list. So yeah, that's kind of important. And I guess flowing on from that, handing over is mainly about pre and post shifts, and getting handover is just as important as giving handover. And I always struggled with this, like when I was first starting out, and I guess you just realize after doing the shifts what is achievable and what you need to receive in terms of handover jobs. And I don't need a big, massive, non-urgent job to be given to me in a cover shift, because things crop up, and honestly, that job just doesn't get done if there's a lot of non-urgent things that are pushed onto the cover doctors, and urgent jobs or situations or patients deteriorate in that time. That's what I prioritize, and that's what other people should prioritize. So having non-urgent jobs pushed onto cover or night shift people is probably not the most appropriate thing. But say you just need to be really specific and say, this person's got a blood test due at 6 p.m. I need you to check that blood test, and if it's really abnormal, then I need you to escalate to the senior registrar. And that's a really simple task that you can hand over to someone, and getting good at synthesizing why that patient's come in, what their details are, and why you need this blood test or x-ray or whatever it is. So those jobs for handover are super, super important. And then, going on from that, ordering and interpreting basic investigations, you'll get better over time, but having an idea that if someone comes in, then you need to order these tests or make sure this scan is done. If they have a fever or they're septic, you need to take a few blood cultures and then send off whatever other cultures to, find out the etiology of the infection. And yeah, just having those on your phone, like as a list of things to order, is not a bad idea. I've got a few things saved on my phone that, if I need to order X test, then I should put this on the slip. And if a patient comes in with this presentation, then maybe I should be thinking of test A, B, and C to exclude above. And, maybe you need a broader testing for different types of respiratory infections. What things should I test for? Here's a list of them. And yeah, you get better at it over time, but having a list on your phone of just like things not to miss, when you're ordering stuff, because not everyone's going to tell you need test A, B, C, and D. And when you first start out, of course, you need to just ask people, do you want this test or do you want that test? And one of the things that you do at the end of the day as an intern, especially on the wards, is work out, well, who needs blood tests in the morning, or who needs this scan done, and when is it going to be done? Because I guess you're usually on the ward if you've got a primary ward job, and the senior doctors are primarily off the wards or in clinic or in theatre or wherever, and you're not always going to be told what to order and making sure things are ordered. So you have to take some responsibility. And as I said, you get better at it over time. But that's one thing to understand. The other thing as well on the ward is managing your pager or your phone. Different hospitals have different setups, but if you're at a hospital that has a pager or some sort of phone, making sure you understand that it has batteries and you need to make sure it's charged, it's working, you're able to receive messages, you're able to understand how the buttons work, and etc. And once the job's done, then you can delete it, or if there's a lot of jobs, maybe you need to escalate and get some other people to help you out, and just having an idea of how those sort of work. I've got a couple other videos showing you how to use your pager, and everything's going to be different depending on what location you're in and what health service. But there is a pager for which you carry, and you receive messages from either nursing staff or other colleagues or whoever, the pharmacist or physio or allied health or whatever it is, trying to get in touch with you. And you just need to make sure you're on top of them, you're checking it. the sound is on or the vibration is on, so you can get notified appropriately, and you don't just like leave it in some random part of the hospital and then people don't know how to reach you. So yeah, making sure everything's charged is super important. That's the basics of the ward. So let's go on to the next one. All right, so next up, we're going through the basics of the rotation that you're starting on, whether that be ED or cardiology or infectious disease, or maybe you're on the general surgery unit. You just need to understand that for each unit, it's going to run slightly differently. And you should have an idea about this rover, which is like this rotating roster or handover document that you should read a few weeks at least, I guess, before you start that rotation, so that when you start, you have an idea about how the unit runs, and you're not just asking all these questions about really basic things that you could have just read like a couple weeks before. And in this document, I guess you have people who have been on this rotation before, who have done the same job, who have been in your position as an intern, working in cardiology, and thought, this is really important for the next person to know. And if I knew this beforehand, it would make my life 20 times easier. So reading through it, having an idea of the overview of who people are, just having the names of the heads of unit, the consultants, the registrars, the numbers you need to call, what time is clinic, what time is theatre, when do we start the ward round, what should I have done before we start the ward round. And, maybe you said that there's some information about basic conditions or medications that, that work, and what about we accept this person and that person, and if a person has X condition, then we need to consider transfer to a different hospital. So yeah, the services of the unit is also limited. A cardiology or a general surgery unit anywhere can't do absolutely everything, and there's going to be limitations to what people can provide and what hospitals can provide. So I think that's one thing that you don't usually think about, is that hospitals and people are not limitless resources, and can do absolutely everything in the world. So having an idea about the scope of practice, how the unit runs, how many people there are, when you have to be there, when you can leave, what is the structure of the basic unit is super, super important. And then leading on from that is actually doing some research into that specialty. Even if you don't like it, even if you have no interest in pursuing it as a career, you should, when you're working in it, try to get the most out of it. Try to get as much information and knowledge and exposure and patient information and procedural information, or go to theatre or clinic or whatever it is, you should actually try to extract as much as you can out of that rotation. So putting some research in, understanding what the basic sorts of presentations are, what conditions are pretty common that you should expect to be able to manage, and medications, looking at different imaging, or how you actually go about doing this procedure or that procedure, and what sort of operations you might encounter. So you deal with the post-operative consequences, even if you are not directly involved in the actual operation itself. So having an overview of the rotation, how it works, and the specific unit is super important. And as I said here, you shouldn't do it at Sunday night at 8 p.m. before you start your round at 6:30 on Monday morning. This should be done like weeks in advance, and you should actually talk to the people in person, show them around before you actually hand over and start your new rotation. So that's what I would strongly suggest. There's so many instances where handover is a little bit haphazard. It doesn't happen until quite late or not at all, and it's very frustrating for the people who are still on that rotation, or the senior doctors, if there's not a good handover, because it just shows that you're not really sort of respectful of those people's time. So having a good handover is super important, and making sure you read the rover and making sure that you actually have an idea about how the unit runs is just going to make life a lot less stressful for everyone. So yeah, that's the basics of the rotation. A quick one, but super important. All right, number 4 is common ward calls. Now, I've got this document here, this on-call principles and protocols yeah, you can have it as an ebook, or you can carry it around if you want to buy it as an in-person book. I'm sure there's a few quote unquote copies out there that you could get your hands on as well. But yeah, this guide is super important, and I think it just takes you through the basics of things that crop up, whether it be a patient on the ward who's, post-op and they have shortness of breath, what you should consider. Or maybe they have some high blood pressure and you don't have the first clue as to how to manage that. And they've already had their usual antihypertensive medication, but what's the next step? So having these basic things that you go through that are genuine problems that crop up on the ward, the book is called On Call, is a really good resource to help you manage life on the ward as an intern. Because I think that's the scariest thing, I suppose, is when you first come on as a junior doctor, you are working, sure, you're with your senior doctors, amazing, but when you directly get asked a problem, how are you going to solve it? What's your framework? And how are you going to actually navigate this issue? Because, you can't always escalate to someone. You're going to need to build a framework yourself for basic management techniques. And I guess that's two-part. It's a double-edged sword, that, I suppose, because as an intern, you are a junior doctor. You should escalate appropriately, but I want to frame it in a different way. Like, you shouldn't just be a transmitter of information. You should be a value adder. And I think this is a good concept to understand, is that when a problem arises, say you have absolutely no idea about how to do it and how to solve it, you should value add before you ask someone else. And you should do some basic work that is very, very simple, So say you've got a patient on the ward and they've got chest pain. You can just go and see the person and do a basic history, a basic examination, and, a suggestion of what investigations you might order if you don't want to pull the trigger and, do anything drastic, which is completely fine as an intern. And you say, well, this person has chest pain. You take a history. It's central. It's in the chest. It feels like this. It is this bad out of 10. It's lasted this long. They've just taken, some food and it feels like a burning or refluxy sensation. They've never had it before. They're also like 2 hours after an operation or something, or whatever the story is. Then you just take the history, do as much question taking as you can. Then you do an examination and you say they're hemodynamically stable, they look well, they're actually on their phone texting their mum. I mean, it all provides information for the person to which you're asking the question. And then you say, well, I think it's this, but I probably just want to rule out A, B, and C, and the nurse is getting an ECG done, and they're just monitoring for now, and I'm just giving them a basic analgesia. But what do you reckon? Should I do any other blood tests or anything like that, a scan or something? And when you do that, you're actually framing to the senior doctor which you're asking the question, hey, I've actually thought about this a little bit. I don't know enough to, confidently say it's this condition or that condition, or ordering this test or that test, because I don't know, this is the second patient I've seen in my first week as a doctor. But you're just escalating appropriately and also value adding. That's a completely different situation to when you get a problem and say, I've got no idea. Hey, person in bed 8 has chest pain. What do you reckon? And they're like, well, I've got all these questions that you probably should have answered before you've asked me that question. And that's a very frustrating situation. So if you have no idea and you're stressed and you're panicking and you don't feel like you can manage, of course, you just need to escalate. But if you have the time and you can actually value add before you escalate, and it's appropriate in the time situation, it's not a emergency situation, etc., then I think that's a very appropriate next step to take as an intern. And you can value add without actually ordering any investigations or, prescribing any medications or solving any major issues. You can just package it nicely so that when the senior doctor needs to assess or needs to answer that problem, they can have all the appropriate information, which is the best thing that you could probably do as a junior doctor and as a first year doctor. So common ward calls, those are the basic things you should have a look at. On Call is a great resource for this. You also have some other resources such as hospital protocols. I don't know if you know about this, but you have an intranet full of, CPGs or, guidelines for different hospitals or health networks, and they have their own specific protocols for different situations, whether it's, say, a blocked PICC line or something, or maybe it is a sepsis protocol and they prescribe different medications based on different sepsis origins and all these different things. So if there's a protocol on the hospital network, it literally tells you what to do in that situation. So if you're not confident or it's the first time you're looking at it, just have a read through. You can call your senior doctor, your reg or your resident, and say, hey, I've just been looking at this protocol. Should I just follow this? And they'll be like, yeah, sure, do that. And it's all listed down as per the hospital guidelines. So yeah, the hospital intranet or protocols, the CPGs is what they call them, are super helpful resource as well. If there's a typical problem that arises, or a situation that arises, or a patient presentation, there's often hospital guidelines as to what to do for that situation. So that's really good. And of course your senior doctors, reg, resident, consultant, whoever you need. But usually it's a stepwise framework. So if I was an intern, there's a resident, I'd probably ask them if it's a non-urgent thing. And if that's not able to be answered or solved, or there's no resident around, I'd ask my reg. And then, if there's no reg and you're really in trouble, then you can ask your consultant or another team's reg or whoever. So you escalate in a stepwise manner. That's the common ward calls. All right, number 5 is emergencies. So emergencies, we're talking about code blues and we're talking about MET calls. There's a super helpful podcast episode by Med Conversations. I don't know if they're still making content and everything, but Med Conversations is a bunch of Aussie doctors. I think they're all regs now, plus or minus on the programs for different specialties, but they did this episode back in 2018. And it's all the things you can bring to a MET call, even when you don't know a thing, as a junior doctor. And I think as an intern or a prospective intern about to start, this is a super helpful episode to listen to. It's pretty quick, but it just goes through some basic frameworks, what you can do to essentially value add. It's all about value adding and providing information and the appropriate information to the right people, because MET calls and code blues are just escalations. So you as an intern have encountered a problem. You said, this patient looks unwell, they're hemodynamically unstable. I think I'm really in trouble here with them. I need to get senior doctors in right away so they can help out this person. And you can help out the patient in a bunch of ways without even doing anything, like ordering scans, starting to document. You can just tell people numbers like their OBS or their latest blood tests, or I've been in a few situations like this in MET calls and code blues as an intern, and if you know the patient, if you actually know the patient and why they're in, you can be so helpful to the person who's coming in to assess them in that critical situation. And if you can just summarize their problem and their progress in 3 sentences, that's just unbelievable for the person coming in. It's such a smooth transition. They say a person is severely hypoxic, you'll put them on oxygen, they've also got some abdominal pain, and you say, the med reg comes into the MET call and, they say, all right, what's going on? And you just hit them with this is a 50-year-old male, day 3 post laparoscopic cholecystectomy. He's been going okay, but he's been kept in because he's been persistently febrile post-operatively. He's opened his bowels recently. He had a few vomits just 2 hours ago and then developed this abdominal pain and became short of breath. This is what I think's going on. I've ordered tests A, B, and C. His blood tests have been okay, but he's just this come out of the blue, and or whatever, and it could just be an elective laparoscopic cholecystectomy. He's got all these issues, and then you just give him the past medical history, what medications they're on. If you can just reel that off and escalate that to the senior doctor who's just come in, they get a complete context of that patient, and it's a really nice situation when that can take place. Obviously, that's later down the line, and you won't be crisp and quick, and And I think just to understand, that's just like a later down the line goal, and it's okay not to be crisp. It's okay to like blunder through it and not be the sharpest cookie in the room with everything, but just providing bare basic information because you know the patient to other people who don't know the patient is very, very useful. So yeah, listen to this episode. I'll put a link in the description. It's very helpful. I think, MET call stands for medical emergency teams. There's going to be different people in different hospitals who attend the MET calls and attend the code blues. But yeah, I guess getting familiar with those. In MET calls, there's usually a medical registrar, there's an ICU liaison nurse, there's the bedside nurse, there's the nurse in charge, and then probably the senior doctors on that team as well should probably attend the MET call. For code blues, there's more people, anesthetics regs, ICU regs, there's medical regs as well, and I guess the primary treating registrar will come, as well as the nursing staff and ICU teams. So yeah, having an idea about the basic people who attend those, it'll differ depending on which health service you're a part of, but that's a good idea to understand who's who in that situation. And I've just popped a picture of an obs chart there as well, just to understand that, you know, the white is normal and the yellow is sort of, you know, maybe I should just escalate to the junior doctor, and then if it gets into the red zone, you really start to worry and you should start to call a MET call for those sorts of people. So yeah, that's just how that obs chart looks like, and just a basic introduction about how you can actually be very useful in those emergency situations as an intern. And I guess to cap it all off, if there is some sort of situation and you're worried about the patient for whatever reason, calling a MET call and calling a code blue, and then immediately people getting there and realizing it's not an emergency is a completely okay situation, because the alternative is so much worse. If you didn't call that emergency code and the patient deteriorated and got worse, that's a much worse situation than calling it, people standing it down and saying that's actually completely fine, I can totally see where you're coming from, or even if I don't see where you're coming from, that's fine. People always say they would rather stand down code blues and MET calls for benign situations than not call it and then people deteriorate and get worse. So I think that's a fear as a junior doctor, is making a mistake and then people being angry at you for it. But this situation is totally fine. So call an emergency code, that's fine. And people will stand it down. If there's nothing to do, all good. We'll just go back to life as normal on the ward. That's completely fine. The other thing as well, as I haven't put on here, is that you should save the emergency number to a call if you're worried about someone. There's nothing worse than you get in the hospital, you're worried, but you don't know who to call and you don't know the number to call, even if you know who you want to call. So I guess just having the number saved in your phone so that you could call someone in that situation, you don't have to think, you don't have to remember, you can just focus on the patient primarily, and then, you know, someone is able to call the number and then call it over the tannoy, the loudspeaker, and other people can arrive, and that's the best thing. So having that prepared, that number saved in your phone, is really important. All right, next up, medications and prescribing. So I think one of the things you should get your head around as a junior doctor is not remembering every dose, every medication, every indication for it, but having an idea about where to go. And we're getting into the nitty-gritty of essentially becoming a librarian. You want to, as a junior doctor, is know where to go to get access to information, and building up your clinical library of resources is going to just be like, it's just going to 10x you as a doctor, because you start to realize that it's not important to know everything off the top of your head. It's just important to know where to go. And even if you've been in the job, in the role for 5 years, 10 years, having an idea about who to rely on to double check things is the most important, because there's nothing worse than just realizing that you're overconfident and you are too bullish to check a resource or whatever. So just trying to realize, hey, I'm not a hero. I think I know this 95%, but I'll just double check just to be sure. And then on the 5% chance you are wrong, then you can just correct yourself, and that's totally fine. And that if you're having an off day and you're a bit tired or worn out and you just forgot a medication dose or the indication or whatever it is, you can just reiterate, just double check, go over. So these couple of resources I've got listed down the bottom are really key to surviving as a junior doctor. So you've got MPS MedWise, it's just the National Prescribing Service. I can't remember what MPS stands for. You've got MIMS, you've got AMH, the Australian Medical Handbook, you've got ETG, which is the Electronic Therapeutic Guidelines, and you've got your pharmacist who lives with you on the ward or in the emergency department or wherever, and they can answer a whole bunch of questions because they've seen all these interns go before them and they've had all these questions, the dumbest questions being asked. I've asked the dumbest questions to them. No question is dumb enough not to ask. And I think that's the thing to understand, is that if you are unsure about something, especially if it's medication or prescribing questions, I think it's just important when you get to this medication and prescribing stuff, you just have to see a few prescribing errors written on paper or in some modules that you learn about in med school to realize it's just important to ask people about clarification of doses, etc. So they're just very avoidable mistakes. And even if it's just filling out the medication chart properly, or realizing that this is a contraindication to this medication, and understanding the class of medication, the mechanism of action, the dose and the contraindications, and when to dose adjust or everything. There's so many different complexities, but if you're not sure, consult a resource. If you're still not sure, consult a person like a pharmacist or a senior doctor, and they may have some further ability to clarify your question. So yeah, all these resources are very, very helpful, whether you can just access them through the hospital intranet. I know AMH and MIMS and MPS MedWise you can actually access without having a profile, but AMH and MIMS and ETG you should be able to access via the hospital system, and the hospital usually has a prescription to that, or the clinician's handbook, and you can just get access to these, because they're usually, if you log into the ETG on your own computer, you can't actually get access to everything. You need an institutional login, or you need to actually pay a personal subscription fee. So those are the things with a lot of these resources, is that they make money because the hospital has a subscription to them. And yeah, the pharmacist is just on the ward with you or wherever. Yeah, I've just taken a screen grab of the MPS MedWise. They have this medicine finder, and it's for health professionals. They have really good information about the indication, the brand, the active ingredient, the doses and stuff. But equally, they have this information on AMH or MIMS or wherever. So, and also ETG too. Having an understanding about the common drug classes is important. Antibiotics and analgesics and different anticoagulants, whether that be warfarin, or maybe it's one of the new oral anticoagulation agents. And just having a stepwise framework to different medical conditions is important. And you can marry this with on-call and just the hospital protocols, or even the handover guidelines that you get, and just your basic interactions with patients and regs over the course of your rotation. You'll build up a framework of what medications to prescribe in the first instance, and then how to escalate to step 2, and then to step 3, and then to step 4. So you can accumulate this information over time, and you will develop your library of resources and stepwise frameworks. Like, I do in my head have an idea about what analgesia I would use to treat pain, and whether I need to continue treating the pain to my guideline, or if I need to escalate and ask someone else. People in pregnancy, have, different requirements and contraindications. So if there's a person who's pregnant and they're in pain, and I've just tried the bare basics and I need to ask for some advice, I'm just calling my anesthetic doctor on call and just saying, what do you reckon for A, B, and C? So yeah, having a good indication of when to prescribe versus not to prescribe versus to ask is a good idea to gauge. So yeah, there's a few things here that I think we've covered. The other thing is just understanding the PBS restrictions. So there are certain medications that have restricted sort of criteria, and you need to get an access code to order to prescribe them. I just have it saved on my phone as like the PBS approval number, and you just call them up if you need a code for a restricted medication. You give them the indication, you give them the quantity, and how many repeats you want, etc. And you essentially talk to this person on the other side who's not a medical professional, but just checks all the things that you are asking for, and then we'll provide you with a code at the end of it, and you can now prescribe that medication to the patient. So yeah, there'll be certain things that pop up and need a approval code, and that's just one thing to understand that I really didn't know about until I started working. Number 7 is imaging. So yeah, you'll have to order scans for different patients. Depending on the hospital network, you may have to do this thing called protocoling scans. Protocoling scans just means you have to get approval from the radiologist registrar, and they will say, yes, you can do this scan, or no, you shouldn't do this scan, or maybe you should do A, B, and C before you do this scan. Or maybe they might say, I don't think they need this scan, I think they need the other scan. And then, yeah, you can sort of like go back and forth with them a little bit. But protocoling scans I really like. We did it at a hospital I was at previously, and it sort of gives you a good level of understanding about why you need the scan and what it's going to show you. And they can quiz you and everything. And I think it's good practice for junior doctors to further clarify their understanding of the patient and the progress and why they are doing certain things. And it's all about, optimizing tests and ordering appropriately and choosing wisely. Choosing wisely is like a campaign that sort of advocates for this in terms of ordering the right investigations for the right times and indications, rather than just doing shotgun approach to ordering stuff and finding random results when it's not really indicated. So yeah, that's important. But if you have any issues with that, then you can just escalate to your registrar or whichever colleague on your team if there's any pushback, and they can have a discussion with the other person. But yeah, you may not need to protocol depending on what health service you're at. If you're ordering an MRI, you can see it on here. They have an MRI safety questionnaire. Essentially, some people have different things, whether it's an ear implant, or maybe they've got a pacemaker, or they've got a history of metalwork or welding or something, or metals in their eye, may have a contraindication to an MRI scanner. And you need to ask them that for every person who's doing an MRI, so you make sure the safety questionnaire is ticked and no adverse events happen from an MRI that gets done for a patient who shouldn't have an MRI. So that's important to know. I've just got a photo of like a request form for one of the radiology companies that we may fill out a form for, and you can see there's a whole bunch of different things to tick for different scans and whether it's urgent, and you have this procedure and clinical notes section which you can essentially just fill in the details about why you're ordering the scan and what your question is that you're asking. For CT scans that have contrast, you should have a kidney function test, that is recent. And if they've got very bad kidney function, but you still want a contrast scan or something, then you may need to do this thing called pre and post hydration. And I guess the pre and post hydration is sort of giving the kidney a bit of a buffer. So when you use contrast, it doesn't give the patient an AKI, and you can give them IV fluids before the scan for a few hours and after the scan for a few hours. And each hospital is going to have their own different guidelines, but you can just sort of look at that or talk to your senior registrar at your hospital, and they can guide you as to how to approach that hydration for contrast scans in patients who don't have the crispest kidney function. And then one other resource which you can use is super, super helpful. They even have a medical student curriculum, is Radiopedia, and Radiopedia is just a free to access resource. It's got a bunch of cases and you can look at the scans, you can see the findings. I think that's the most important thing, is when you have a scan and there's a finding, you need to be able to recognize it. And you only realize what's normal or abnormal by looking at scans. Having, images that you look at, cases, and you can get shown what the findings are. And Radiopedia is a good example of where to do that. And they can actually take you through different signs that you can pick up on scans, so that if you have a person who's on the ward who's got a scan, it's not reported by the radiologist, you don't have the quote unquote answers, and there's no arrows that are pointing to the specific sign they're talking about, you can actually look at that and say, I think it's this, or I think it's that. And some of the best conversations I think I've had is with radiologists, where I've done a bit of research into what the scan I think shows and what finding I think I'm seeing. And when they actually clarify with you and talk you through what they're seeing, the radiology registrar, or maybe it's a radiology consultant, they can actually provide you a lot of good teaching. And yeah, as a junior doctor, calling up and asking for some phone advice and saying, hey, I think this patient's got, a bit of inflammation here, or I think I can see a stone here, or is this like actually, a bit of gas I see, or what do you reckon about this? It looks odd. And then they can clarify, hey, it's actually normal. If you look at this on the axial scan, it's a bit different to on the sagittals, etc. So yeah, they can really talk you through how to interpret images and actually show you how to look at them properly, and the different settings or almost cheat codes that they use. So yeah, looking at scans, practicing looking at them is a super important skill that you should get good at as a junior doctor. All right, time to talk about some money. Money things is something I'm pretty passionate about as a junior doctor, and it's really not explained that well, and you're sort of expected to understand a whole bunch of stuff without actually being taught it. So I go through a few things that I'm sure you may have seen in my other videos, my pay slips, my overtime and salary packaging. But essentially this is just a screen grab of one of my recent pay slips in September, I think. And yeah, it's just, I just go through in my other videos about how to, interpret what you see on your pay slip, and what you essentially get paid and how it works. And say you worked like 10 hours of overtime this week, what money you should be expecting to see on your pay slip and what rates it is at and everything like that. So understanding your pay slips is important. I'd just say watch one of my videos about that. I'll go through everything. But having an idea about how to check your pay slip, each health network or state may have a slightly different pay structure. In Victoria, what you can do is you can use this resource called DIT Paycheck. I'll pop a link in the description, but essentially gives you the option to input your hours that you work, and it generates a mock pay slip. I did a video on it as well, just comparing it to my actual pay slip, and it's good to see the differences that may pop up. And if there is a massive difference and you're missing, say, $600 or whatever, you should contact your payroll with that and say, well, hey, I think I missed out on a couple hours of work here. Do you mind just fixing up the pay slip? And yeah, there are errors that occur for a whole bunch of different reasons, but having a good idea of what you're getting paid and how much you should be getting paid is an important thing. No one works for free, and you should actually have an idea about that and learn about it. I think it's very interesting. Same thing with overtime, keeping track on it. One thing you should understand is that overtime needs to get approval, and you need to have indication for overtime. Each hospital may have its own different, criteria, what you're doing your overtime for. Is it a medical emergency? Is it documentation? Is it, some other reason that crops up? You have a shortage of staff or something. So having an appropriate log of why you're doing the overtime is good. You need to do that. It can be very, easy just to finish the shift, go home, and then just quickly jot a few hours on your phone or something like that. But just make sure you have a reason why you stayed overtime, because keeping track of it is one thing, but doing the overtime, not keeping track of it, trying to claim it not really adding up, and then people question, well, why did you stay, and you don't have a good reason. It's not going to be the best look if you try to claim that. So having a good documentation and log is always the best case scenario. So if you stayed for an hour or two, after your shift finished because there was a sick patient who was deteriorating, or maybe you needed to do some clinic notes, or maybe you needed to actually finish off the discharge summary for a patient who was going to get transferred and there wasn't anyone else to do it for you, then that's an appropriate reason to claim the overtime. Just make sure it's logged, and people most of the time, I say most of the time, quote unquote, because there's obviously issues of not being paid overtime, but depending on your unit and everything, I've never had an issue trying to claim it. But yeah, try to keep track of everything. That's the main thing. Salary packaging is an interesting thing. You probably won't know much about it if you're first starting out as a doctor. Salary packaging is a way of just using money that's not being taxed to pay for stuff. And each person who works as a doctor in the public health service gets a certain portion of that to be allocated that doesn't get taxed. And I reckon, I think the living expenses, I haven't spoken about this for quite a while, so I'm a bit rusty, but you have about $9,000 for each health service in Victoria to get salary packaged. It's different in, say, New South Wales or other states, but you can't do the whole multiple health service salary packaging thing. But for your living expenses, rent or whatever, groceries and everything, you have about $9,000 worth of that to allocate. And for meals and entertainment, you have like $2,600 to allocate to that. So there's all these other things that you can salary package and additional ways you can salary package, etc. I've got a whole video on that, deep diving everything and going through how it looks for me. So check out all those videos. They go through a whole bunch of stuff that going into that. But salary packaging and the crux of it, you should try to maximize it for an intern for the first few months, because the end of the fringe benefits year does end at the end of March and then restarts at the 1st of April. So you do have a chance to salary package twice in your internship, and I'll explain like what that means and everything in my other video. So yeah, that's money things. I certainly got a lot out of this, deep diving into how things work, and I certainly didn't have a clue where to start when I first started working as a doctor. So if you start to consume a bit of this content and get your head around a few things, it might just make things a lot easier for you. All right, number 9 is going to be some teaching. So with teaching, you have a few different options. As an intern, I think you do have weekly teaching sessions that you should go to. You're allocated, it's protected teaching time is what they say, and you should essentially give your pager to your senior doctor and say, hey, I'm going to teaching for this next hour. I should actually go and learn and not be interrupted by ward jobs, and that's the ideal situation. I certainly try to go to teaching as much as I can as a registrar, and as a resident I tried to as well, but things crop up, and sometimes the best sort of learning is whatever is happening at the hospital, whether it's scrubbing into that operation that you don't get to see, or seeing patients in clinic and everything. But you need to consolidate all this with actual lectures and tutorials. So that's really important for you. And yeah, you should have allocated intern teaching each week. But there are always like other opportunities to learn and to get taught stuff at the hospital, whether it's just impromptu admissions or discharge summaries or questions that crop up on a ward round, or maybe it's procedures that you get exposed to, or operations, or whatever deteriorating patient that comes up. So yeah, having just exposure to different things on the ward, cover shifts, weekend shifts, night shifts, doing a whole bunch of things at the hospital, you will see things that other people won't. And having to take stock of those situations, analyzing it, looking at why that patient was sick, what happened, how that procedure was done, making a note of it so you can apply that to a future situation is going to be really important. But structured clinical sessions, yeah, you will have teaching, you will have procedural skills. I mean, remember doing ED as an intern and get specific ED teaching, and they're very big on that in the emergency department culture. And you learn how to do ultrasound guided cannulation, you do fast scans and all these other things, that you may have not been exposed to. So having procedural teaching and surgical teaching, as well as, didactic teaching with lectures and shoots is just as important. So yeah, you will have structured teaching embedded into your work schedule, your work roster. So yeah, try to get that protected. And if you can, hand off your pager to your senior doctor and say, all right, I'm going to be teaching now. If there's anything that crops up, can you please assist? And I'll be back at say 1 o'clock or whatever it is. Next year and beyond is a really good point to sort of consider at the back once you're a few months in, because people apply for jobs halfway through the year, and there's a few different options when you start to, go into that next year. I think they're doing a 2-year internship now, so it may be, next year and beyond. But I guess having an idea about the general trajectory at which you're going to go into, and whether it's going to be a more medical route in terms of BPT, basic physician's training, or if you want to do more of a surgical resident role, maybe it's peds or obstetrics and gynecology, or maybe it's leaning to the GP pathway. So there's a video I did recently about the different pathways and specialization and how to look at how to do that. There's a specialty finder website that I'll put in the description, as well as the video I made about it, and you essentially get to look at the different options and pathways into each specialty that you may or may not be interested. But the internship, as its core, is about sampling a few different specialties and making sure you tick the main criteria and passing and getting your general registration. So ticking off all those boxes and getting exposed to different rotations and specialties in the hospital is super important to guiding your career direction. So having an idea about where you should go or where you may want to go in the future is something to keep in the back of your mind when you're working. And after you're like surviving and doing all those things, then you can think about this. But other things that you could get done in this year or this 2-year period is exams. Build your references and start doing research, and that's something that comes secondary to looking at which direction you want to go at. You don't just do research for any purpose, you don't just do exams for any purpose, and you don't start aligning yourself with people for any purpose. You need to have direction and intent with things. So if you're aiming to get into surgery, or specifically vascular surgery or neurosurgery or something, you should have an idea about how that department works, what sort of things people may do to get onto that program, and where you sort of need to go, what direction to try to get yourself in the best position. So yeah, have a look at the video that I made going through the different specialties. Then from that, you can sort of reverse engineer things, look at what exams you may need to do, whether it's the GSSE, whether it's a specific specialty exam, whether it's, you need to sort of get involved in this research for different things, or, when you need to apply and what sort of references you want to get for those jobs. So yeah, having a look at the general lay of the land is important moving forward after the internship, because once you complete it, then you need to know what you're going to do next. Key takeaways, obviously I'm just a bit stunned here, so that's why I put it in there, but you've been through this whole tour and you've come to this situation. You're wondering, what do I get from internship? What am I supposed to take away? And I guess after survival and exposure to different health services, you need to figure out what sort of way you're leaning in terms of, did I like surgery? Did I like the medical rotations? Did I not like anything and I want to get out of the hospital and do GP? Or do I really like the high intensity deteriorating patient environments and I really want to be in that ICU or critical care environment, maybe emergency medicine or something? So, having an idea about what you liked, what you didn't like, and what you should want to do more of in the future is a really good reflection point. But yeah, I guess the crux of it is, this is a job, yes, but you also have your life as well to do in the interim, and not just in the interim, but like for full time. You also have your life and other goals and accomplishments and things that you want to get done outside of work. So having an idea about how those two marry together and how that may work in terms of a 30, 40, 50 year runway for a career is important to understand. So yeah, thinking, do I want to be a surgeon, and do I want to be on call, and do I want to wake up in the middle of the night to do an operation, or do I want to clock off at 5 and say that's my job, and if there's anything urgent then they can go to the emergency department, but I'll rock up to my GP clinic at 8 o'clock on Monday morning. Whatever it is, just have a think about what sort of environment you want to work in, what people you want to work with, and what sort of patients you want to deal with as well. So yeah, I guess that at the crux of everything, internship is going to be a really fun experience for you. I certainly had a whole bunch of ups and downs in internship, but overall, towards the end, I think I really learnt heaps and had the best year. To be honest, it's so much better than medical school, just as much as medical school is better than undergrad and high school and whatever. So you're just doing more cool stuff. So maybe this is the talk that you listen to just before you start internship, 2 hours away from now, or the night before, or maybe you're a medical student just getting into everything. This is a good talk to just have a look at, have a watch, and just understand what to do and what to take away before you get started. So yeah, if you are getting started in your first year as a doctor, good luck, you'll smash it. Or maybe you won't smash it, and then you'll get better at it, and you'll get better over time, and it'll be fine, because that's what I did, because I definitely didn't smash it. So maybe just have a good think about a few of these things that I've spoken about, and you'll make it work, I think. All right, we'll see you next time. Bye.